Hello, friends. Greetings from India again. And thanks once again to Dr. Andrew, Dr. Jackie, Professor Moindi, and the entire Kenya group for having me here. So, today I'll be speaking to you about bronchoscopy in tuberculosis and infections, primarily focusing on the diagnostic roles and the biosafety. So, moving on to the tuberculosis, bronchoscopy plays a very important role in tuberculosis. It can be in the form of diagnosis, where you try to see about the lymph node compressions of the airways, endobronchial TB, the complications associated with the tuberculosis, like bronchoesophageal fistula. Also, to confirm the presence of either a drug sensitive or a drug resistant tuberculosis with the help of the BAL, where you send it for gene expert and you also send it for cultures. Sometimes, if you see an endoluminal lesion, you take a biopsy. In centers where you don't have an EBUS, you can still do a TBNA from these lymph nodes to confirm the presence of an mediastinal lymph node tuberculosis, as well as EBUS and USB FNA. Apart from this, the bronchoscopy also has a lot of role in the interventional aspect, like endoscopic enucleation, debulking of lymph nodes, closure of the fistulas, management of hemopsis, and even in certain conditions to monitor how you are responding to the treatment, whether you need corticosteroids or how to see if the endobronchial tuberculosis is responding or not, and to intraoperatively guide surgical decompression of lymph nodes. But when we say about the diagnostic aspects of the bronchoscopy in tuberculosis, the primary modality that we use is a bronchoalveolar lavage. And this is primarily sent for two different entities. One is called as the gene expert and liquid culture. Sometimes we use the line probe assay as well. And it is also in certain conditions where you exactly want to go to that particular segment and take a BAL, you can even use your thin or ultra thin bronchoscopes. And as I said to you before, it can be even used in endobronchial ultrasound, as well as reduce the use of lignocaine for local anesthesia. This is very important because they say that if you give a lot of lignocaine during the time of your bronchoscopy, you may get a gene expert positive, but the culture turns negative because hypothetically the lignocaine tends to have a growth inhibitory effect on the mycobacterial cultures as well. But one important area where bronchoscopy really plays an important role in tuberculosis is in the identification of an endobronchial tuberculosis. When we say endobronchial tuberculosis, we mean to say that the microbiological and histopathological confirmation of the bronchial tree involvement by tuberculosis. It can be because of a direct extension from an adjacent parenchymal focus, or it can be an implantation of the organism from the infected sputum, or it can be because of hematogenous dissemination, or in certain cases, the lymph node eroding into the bronchus, or spread of infection via the lymphatics. So Chung et al. Has classified the endobronchial TB based upon the bronchoscopic appearance into either a non-specific bronchitis, bronchitic picture where you will have a tracheobronchial mucosa which is slightly swollen and hyperemic. The second variety is the edematous hyperemic variety and actively caseating. So this is sign of endobronchial TB. When you can see a picture like this where there is an active caseation, cheese-like material, you know that you are dealing with a case of an endobronchial TB. Sometimes you can have a granular appearance like a rice-like nodules, and sometimes you can have an ulcerations in the tracheobronchial mucosa. And tumorous forms of endobronchial TB are also reported. But the dreaded complication of all these sorts of endobronchial TB is the fibrostenotic variant. So where there are cases where the patient has essentially lost an entire lung secondary to the bronchial stenosis, and patient suffers from debilitating breathlessness, especially due to the involvement of the trachea by these tuberculosis. So I'll just take you to two or three cases to make you understand what this endobronchial TB can really make a difference in the life of the patient. For example, this patient was a 43-year-old female, no comorbidities. She was treated as a case of an uncontrolled asthma. Later came with complaints of breathlessness, cough, and minimum sputum. You get a X-ray here, you got a CT chest. The CT chest is classically suggestive of right upper lobe central lobular nodules or the trine bud nodules. Sputum came out to be positive for tuberculosis. We could have stopped at that stage, but in the CT scan, we found that there is an element of an airway involvement. So we went ahead with a bronchoscopy, and in the bronchoscopy, what we observed was a caseating form of an endobronchial TB. So this is a warning sign. Let's say you have not done a bronchoscopy, you have just treated this patient with an anti-tubercular therapy. Possibly this patient could have developed a permanent stricture or a stenosis of the airways. So what we did in this case was, once we know there is an endobronchial TB, you started this patient on ATT along with systemic steroids. And at the end of the treatment, you can see there is a near complete resolution, but still some plaques of the endobronchial TB are left. So this is at the end of 3 weeks. So the important point is you need to have a high suspicion of an endobronchial TB. And if you diagnose an endobronchial TB with a bronchoscopy, always start ATT with steroids. Now I'll take you through a very, very interesting patient. So this patient came to us from a northeastern part of the country where the patient was having a sputum positive tuberculosis. And the patient was perfectly fine in the X-ray, except that if you carefully notice, there is some volume reduction on the left lung. But however, the patient was started only on TB medications. But at the end of the treatment, you can see that the patient had a complete collapse of the left lung. And a patient who was completely normal before the ATT initiation, at the end of the ATT, he became completely oxygen dependent. So what we are seeing is a case of a dreaded fibrostenotic variant of an endobronchial TB, which caused a complete collapse of the left main bronchus. And now, as you can see, I am passing the bronchoscope. There is no left main bronchus left. But in this case, we were lucky enough, we were able to identify what could be the potential ostium of the left main bronchus. So what we are doing is the blunt dissection of the tract with the help of the Fogarty balloon. And since it was only a membranous form of an stenosis, what we were able to do was we were able to rupture the membrane and we were able to enter into the left main bronchus. And then we did electrosurgical incisions on the left main bronchus. And then we were able to make sure that we are in the path which is leading into the left main bronchus. And once we know that we are dilating with the help of the CRE balloon and all the pent up pus which was there in the distal airway lumen was collected. And now you can see that the left main bronchus was completely recanalized. And sorry for the technical glitch. So the left main bronchus in this case was completely recanalized. And as you can see from here, there is a complete recanalization of the left main bronchus. And to our surprise, you can see that the X-ray, which was like this, immediately post-procedure, the patient had a complete expansion of the left lung. And even at the end of the 6 months, there is complete expansion. And now the patient is on 2-year follow-up without no residual stenosis. But this is a very rare case. There are instances where, because of the complete stenosis of the left main bronchus, you will not be able to retrieve the distal lung as well. This is yet another patient for you to understand what endobronchial TB can do to your airways. For example, this patient had sputum positive tuberculosis, had a persistent wheezing. We did a bronchoscopy. There was presence of endobronchial TB in the form of a nodular type. We took a biopsies to confirm the presence of a granulation tissue, and we started ATT with steroids. But despite ATT with steroids, the patient had worsening of her endobronchial TB. She was a young female, and now you can see that the left main bronchus is almost near completely occluded by the tumorous form of the endobronchial TB. This is a very, very dreaded complication. So in this case, what we had to do was we had to go inside with a bronchoscope, and then we had to debulk all these granulation tissue, and then we have to do the cryo extraction of the granulation tissue, and then we have to place mitomycin to prevent any sort of a restenosis. And then we didn't put a stent in this case, and then we continued the ATT along with the steroids. And at the end of 6 months of treatment, now you can see that the airway is relatively much better, and the left main bronchus is completely recanalized, and the patient is doing fine. So for identifying an endobronchial TB, your bronchoscopy is the primary modality, and it plays a very, very important role in establishing the diagnosis of an endobronchial TB as well as in providing curative intent treatment for these patients. Apart from that, with respect to the pneumonia, the indications of the bronchoscopy include identification of an atypical bacterial organisms, especially with the upcoming of the multiplex PCR in the bowel sample. You can identify all sorts of atypical bacterial infections as well as certain viral infections. And if you have a non-resolving pneumonia secondary to a atypical organism like a nocardiosis, then you can find out with the help of the bronchoscopy specimen with a high confidence using the modified AFB stain or the ZN stain. And even in certain cases in bronchiectasis where you want to identify a non-tubercular mycobacterium, you can use the PCR and the liquid culture to identify these things. And most important thing is for identification of fungal infections, especially when it comes to the mucormycosis or invasive aspergillosis, your bronchoscopy plays a primary role. In addition to this, in certain conditions of immunocompromised state where you want to identify certain organisms like a pneumocystis carinii, you can use a PCR or specific staining, and atypical viral infections like a CMV or herpes can also be identified. But the biggest utility when it comes to the ICU setting is the use of the organisms to send for biofire funnel through which you can identify certain resistance pattern like a carbapenem. For example, this is yet another patient who presented to us with a right lower lobe aspiration pneumonia post road traffic accident. We did a bronchoscope. If we have not done the bronchoscope, we could have missed this. There was exuding pus, there was necrotic membranes all through the trachea, and these membranes were even infiltrating the airways. So, what essentially was a triple invasive fungal infection of an invasive mucormycosis, invasive aspergillosis, and invasive cryptococcosis in this patient. So, without bronchoscopy, possibly we would not have understood the severity of the airway involvement by these fungi. Similarly, this is yet another patient who was an uncontrolled diabetes presented to us with a cavitary lung disease with a hemopsis, and patient was started on empirical antitubercular therapy from an outside hospital. This time came to us with a hemopsis. We did a CT scan. There was even presence of a pseudoaneurysm because of the invasion of these blood vessels by this pneumonia. And when we did a bronchoscopy, you can find a thick necrotic membrane almost eroding the airways. And we took a biopsy. It turned out to be a case of a mucormycosis, and then immediately the patient was subjected to a pneumotomy and the patient was saved. So when you have these sorts of atypical infections, bronchoscopy comes to the rescue. Now, moving on to the biosafety precautions, yes, bronchoscopy is associated with the safety concerns both for the patient as well as for the person who is performing it. Therefore, it should be performed in a suite or a dedicated place, and it should have all the things for the patient preparation, for the performance of the procedure, as well as the post-procedure monitoring. Every bronchoscopy suite should have all essential equipment related for the patient monitoring, and a bronchoscopy suite should also have dedicated areas for the bronchoscopic infections and storage of the specimens. Whenever feasible, the bronchoscopy should be performed in a room with a negative pressure design, and the bronchoscopy room should have at least 12 to 15 free air exchanges per hour to prevent the cross contamination. And if recirculation of air is unavoidable, then at least exhaust should be used and HEPA filters should be used because these are high infective procedures. And with respect to the staff, personal protective equipment should be worn by all healthcare professionals, especially when you're dealing with a case of a multi-drug resistant tuberculosis, or if you're suspecting any sort of a highly transmissible infections, use of N95 mask is preferred. Healthcare personnel in proximity to the patient during bronchoscopy should also ideally wear an eye shield, and needles should not be used to remove biopsy specimens from the forceps because accidentally it can puncture you and can inoculate these harmful organisms into your body. And all staff should be vaccinated against hepatitis B and should receive an annual influenza vaccine. And impermeable surgical gown should be worn by the bronchoscopist and healthcare personnel in proximity during the procedure. And apart from this, all universal precautions should be taken. And latex or nitrile powder free gloves should be preferably used, and hand hygiene should be emphasized. And all healthcare personnel exposed to disinfectants in bronchoscopy should undergo a baseline evaluation because your bronchoscopy exposure to the detergents and the latex can make you prone to develop occupational asthma as well. And all staff engaged in bronchoscopic disinfection should undergo periodic clinical assessment. And bronchoscopy should be performed in patients with suspected TB who are either unable to produce a sputum or in whom the sputum is unyielding. But if you are suspecting an endobronchial TB, as I showed you in the previous cases, then always do a bronchoscopy to confirm the presence of an endobronchial tuberculosis. And when it comes to the reprocessing of the instruments, there are a lot of terms. When we say about sterilization, it is complete elimination of all forms of microbiological life, including spores. And when we say about disinfection, it eliminates all organisms except the spores. And depending upon the level of disinfection, you can have it as high, intermediate, and low, and chemical sterilization. But when we speak about bronchoscopy, anything that comes in contact with the mucous membrane becomes a semi-critical device and it requires a high level of disinfection. That is why we subject these scopes to the glutaraldehyde or the other high-end disinfectants. But all the instruments that are used to take the biopsies, which will penetrate a normally sterile space, becomes an element that comes under the critical classification and they require sterilization. So, and if you want to remove the spores, especially when you're using bronchoscope for Mycobacterium tuberculosis, then it requires a high level of disinfection. And there can be a lot of areas where there which can result in the contamination of the scope. It can be because of ineffective scopes cleaning, or it can be because of ineffective handling of the accessories. It can be because of the contamination of the reprocessing equipments. It can be because of the installation of the drugs which you use, which gets contaminated. Or sometimes the disinfectant may not be proper one and improper connected to the reprocessing circuit, and recontamination after disinfection, and even storage in coiled position in cases. So it's an exhaustive list. So the only way we can get away from the contamination of the scope is to keep a checklist and to monitor the checklist promptly to prevent the contamination of the scope. And if you see the organisms that are associated in a bronchoscopy related infections, these are deadly organisms. It can be in the form of Pseudomonas, it can be in the form of Serratia, Burkholderia, which can result in hospital outbreaks. But the most concerning thing when it comes to the bronchoscopy related infection is the NTM infection. So NTMs are very dreadful bacteria to handle. And if you get repeated NTM from or an NTM outbreak in your bronchoscopy suit, then it can be because of the contamination of the scope by means of either the water or because of certain other disinfectants. So make sure that you have a quality check. And if these organisms are introduced into your patient and it causes an infection and possibly a disease, then it's going to be extremely difficult to eradicate these organisms from your patient. So safety is of utmost importance, not only for the patient, but it's also for your scope as well as the healthcare personnel handling these high-end equipments. And so how to process the scope? Inspect the external surface of the scope for damage and leak testing. This is of utmost importance. Before you start a scope, even though your sister has monitored for the scope damage and the leak testing, I feel it is the duty of every bronchoscopist to identify for the leak as well as the scope damage and clean immediately after each use and before disinfection. This is again pretty much important because if you leave the instrument with the contaminants, then it is going to form a biofilm, which is going to be extremely difficult for you to remove, and discard the detergent solution after each use. This is also to be emphasized because there are areas where the detergents is reused multiple times, which compromises the safety of the scope in terms of infection protocols. And cleaning brushes should be either disposable or it should be thoroughly cleansed with a high level disinfection. That's very, very important. And if you feel that you are getting if you're not convinced with your high level of disinfection, always go for sterilization with ethylene dioxide. Disinfect with the agent of sufficient antimicrobial intensity at an adequate temperature and for adequate duration. And the preferred disinfectants include the glutaraldehyde, periacetic acid, and orthophthaledehyde, and ensure compatibility between the scope and the endoscopy processes. This is also very important because you need to follow the manufacturer guidelines. Sometimes you may be using a non-compatible scope, which can compromise the credibility in terms of disinfection of these scopes. And completely immerse the instrument before disinfection to check for breaches in the luminal integrity. Non-immersible bronchoscopes should be replaced if economically feasible, and routinely test disinfectant concentration in non-prepackaged kits, and rinse with filter tap water followed by 70% ethyl alcohol or sterile water after disinfection. And sterile water may be necessary if water supplies are implicated in outbreaks, especially if you are getting an NTM infection like Mycobacterium gordoni. And allow bronchoscopes to dry thoroughly in designated areas before storage. Store bronchoscope in a hanging position to prevent moisture accumulation. And use single-use stopcocks as reusable ones may be very difficult to clean. And reprocess heat-stable parts and accessories such as the biopsy forceps by mechanical cleaning followed by autoclaving or sterilization, and do not reuse atomizers between the patients unless re-sterilized. And ensure regular maintenance and disinfection of the automated washers and associated supplies. Maintain a log of bronchoscope use as well as automated endoscope reprocessor maintenance in disinfection. Provide accessible cleaning and disinfection protocol manuals from bronchoscope and automatic reprocessor manufacturers, and it is important to contact the manufacturer to ensure compatibility. But the most important thing is education. You may be an excellent bronchoscopist, but if you're not able to train your staff pretty well in terms of disinfection or in terms of sterilization, then possibly you are exposing yourself as well as your patient to dreadful infections, and it can compromise the safety of your bronchoscopy suit as well. And microbiological laboratories, especially coordination with a microbiologist or an infectious care specialist, is of utmost importance to prevent any sort of these outbreaks, especially when you're getting repeated cases of NTM or Pseudomonas or Burkholderia, because this can indicate that there is a scope contamination or the biofilm formation. And notify the institutional infection control officer. This is very, very important, especially when you're getting Burkholderia infections and such serious infections. So as we have seen from here, maintaining the biosafety of the scope is of paramount importance, and it starts with pre-cleaning, leak testing, manual cleaning, visual inspection, terminal reprocessing, rinsing, drying, storage, and use. But let's say that you are not able to adhere to these norms, or if you're not able to maintain a checklist to ensure the safety of your scopes, then and if you are able to afford, then possibly single-use bronchoscopy is the real alternative. And that is why we are seeing an emergence of the single-use bronchoscopy in the performance of the interventional pulmonology procedures, because safety is of utmost importance more than your diagnostic yield. If you're not able to provide a safe environment for your patients, for your nurses, or for yourself, then the diagnostic yield, whatever the cost it may come at, may not justify the outcome. So make sure that you give importance for the safety, cleaning purposes, and education of your staff and nurses is also of paramount importance. And if you cannot do it, then possibly single-use bronchoscope will be the only alternative. And when we say about the safety is not only for the performance of the performer or the bronchoscopist or for the scope, it also deals with the patients. So, especially when you're using an ICU bronchoscopy, it can lead to tachycardia, dysarrhythmias, bleedings, endotracheal tube displacement, raised ICP, especially in patients who have undergone a neurological procedures, discomfort, pneumothorax, bronchospasm, hypoxia, and hypercarbia as well. So I'd like to end my presentation here emphasizing on the need for the safe processing of the bronchoscope to prevent this cross-contamination of an infection. And this is our interventional pulmonology suite at Yashoda Hospital, Somajiguda. And if any one of you are interested to join us for any sort of a learning, we are more than happy to have you with us. Thank you for the patient listening.